Welcome to Adapting Voice, and thank you for deciding to watch this video. We'll be talking about long sounds and we apply it to clinical situation and common testable questions you see in your NCLEX. And if you're in nursing school, this is also a video that you should know in terms of your physical exams and fundamentals. The basics will be presented, how to recognize them and distinguish between each of them, and therefore stick around and learn something. First, let's talk about pulmonary exams. When you examine a patient, what do? You need to inspect, palpate, percuss, and auscultate. It's the same thing, similar to the abdomen. You have to recognize that your lung, there's a tree surrounded by parenchyma. And this is a case in chest, right? There's three categories of sounds you can hear from the lung. It can be a breath sound, it can be adventitious sound, it can be vocal resonance sound. This is the way I want you to think about. Three sounds you can hear when you listen to somebody. It can be breath sound. And what does that mean? Breath sound is what everybody hears. You see, normal breath sound with the stethoscope. But is that all you need to know? There's different kind of breath sounds. We have a bronchial or tubular breath sound. And you don't have to memorize. What does the bronchial sound mean? You see, it's a bronch and tubular. The tubular structure is the trachea, and the bronchia is right here. So these are the sound you hear at the center portion of your chest, right? Bronchial tubular. So you hear the tracheobronchial tree. And what role does they play? You hear this sound during expiration. When air is coming out, then you hear the sound. They're usually loud, arching, and they have like a high-pitched sound. That is a bronchial sound in the middle of the chest. You can also hear vesicular. The vesicular deal with the lung itself outside the chest by going lateral. So it did with the lung parenchyma. And this is the sound you hear when you take a deep breath, it's inspiration. When you hear expiration sound, it's a brachial sound. So inspiration is common with the vesicular sound. It's very soft and low pitch. It's not high pitch. And it's usually found at the back of the lung, posterior aspect at the basis. So that's the way you can distinguish them. If you combine the two, bronchial, vesicular sound, since you hear aspiration and bronchial in expiration and vesicular in inspiration, this one you hear both inspiration and expiration. It's the mid-range pitch because of the high pitch for the bronchial and low pitch for the vesicular, and it's found on the anterior aspect of the chest. That's where you can hear it. So those are all normal breath sound. When you see a question, they give you bronchial sound, vesicular sound, bronchial vesicular sound. These are all normal lung sound. The abnormal one are the adventitious sounds. And these sounds heard in addition to the normal one. It can be Crackle, it can be Rhonchi, it can be Wheezing, it can be Stridor, it can be Rales. But those are abnormal. They are adventitious, and tissue sounds. Key fact to distinguish between them is two things. First, it can be continuous sound or intermittent. What does that mean? That means you can hear the sound throughout the inspiration or expiration cycle, or you can hear it intermittently. Rhonchi and wheezing, you can hear it throughout the sound, and then intermittent in between during inspiration and expiration, so crackles. And then you can distinguish them based on the pitch. If the pitch is very high, it has to be a wheeze or fine crackles. And if it's low, it's a Rales or coarse crackles. What does crackles mean? It's like you are opening an airway during inspiration. But it depends on which kind of airways you're opening. If it's a coarse and fine, it's based on the size of the airway that you're opening. Think about opening a Velcro, the sound that you make, making crackle sound. What does a wheezing sound? It's a musical sound, and it's like music when air is going through a narrow airway. And usually you hear it either in expiratory, that's why asthma is an expiratory wheezing, or both at inspiratory and expiratory. The Rales is almost like wheezing, but it's different. The air is moving through a larger airway without obstruction. So you hear it mostly expiratory. Stridor is also involved the larger airway, but it's a little bit higher than where you hear Rales and wheezing. So it's all the way close to your neck. So higher pitch during inspiration in the larger upper airway. When you have a rub, that means the pleura is rubbing against each other due to inflammation. So greeting sound from inflamed pleura against one another, and it can be painful. What does resonance means? This is the lung tissue. Just know that it's another sound you hear, but in order to understand that, that lung tissue is low pitch or low pitch passer filter. It allows low pitch to be filtered out, and then usually low frequency move faster than higher frequency sound. Pathologically, you usually will see it in a tissue that is affected. So along that, that's a pathological features like pneumonia. Yeah, you have easy to transmit high frequency waves through that. This is what we test when we're doing like bronchophony or egophony. What does that mean? You put your stethoscope on the patient back symmetrically, and you ask them to speak. They make sound, right? When they make a louder and closer sound, that's bronchophony. But when you like them say A and E, and when you say this, you ask them to say E, they end up saying A. That is the egophony. And this is indicating vocal resonance. What is the clinical implication? It's very important that you know the clinical implication of this problem. Adventitious sound, you know, it's abdominal sound. It's a pathological problem. Crackles will tell you where it's coming from. It's mostly pulmonary edema, interstitial lung disease, or heart problem. Wheezing is common in a COPD patient. And then a bronchial sound is, if it's not central and is occurring peripherally, then it's a pathological. I just made this table for you to be able to distinguish. This is very common. You can be asked to distinguish between sound based on the condition. If there's a normal lung, percussion is going to be normal in terms of a resonance. And the tactile fremitus, this means the sound you hear when you push the vibration sound. When you try to speak, the larynx have a vibration sound passing through the lung to the chest wall. Whenever there's a consolidation, tactile fremitus increases. Whenever there's a lung separated from the wall, like a pneumothorax, yeah, tactile fremitus decreases. So for a normal lung, it's normal. And a breath sound you hear in a normal lung is a vesicular or bronchovesicular. It's easy, right? For pneumonia, there's a pathology. There's obstruction in the lung itself, not true obstruction, but there's consolidation. So the will sound dull. It's not going to resonate because air is not passing through. And the tactile fremitus is going to increase because of a consolidation. And what breath sound you're going to hear? Crackles and egophony. You can figure it out. If it's a pneumothorax, you're going to have hyperresonance. Too much air will making sound when you percuss. And then the tactile fluid, the pleura is separate from the wall, so you have a decreased tactile fluid and fremitus, and then the breath sound is usually decreased or absent. Same thing as pleural effusion. You're going to have dullness on percussion and a decreased tactile fluid. The breath sound is also decreased. This is just a quick video to help you know the difference between long sound, how you can find them pathologically, what indication, what are the sounds that you're supposed to hear. Take care of yourself. Thank you for watching this video. Bye.